I'd like to welcome you to another Journal of Oncology Practice podcast from ASCO. This is Dr. Bob Miller from Johns Hopkins. Well, this is the first time we've ever had a podcast recording delayed by a hurricane, so it's very nice to be back with you again. And our thoughts, of course, are with all of those who were affected. My guest for tonight's podcast is Linda Parreco, who is an oncology nurse and currently a public health advisor at the NCI's Office of Communications and Education. Linda has worked in the area of clinical trials in the community setting. She's worked at a comprehensive cancer center and for the federal government. She and her co-authors from the NCI published a very interesting paper in the September Journal of Oncology Practice entitled Power of an Effective Clinical Conversation, Improving Accrual onto Clinical Trials. Linda, welcome. It's great to have you.
Thank you so much, Bob. I'm really delighted to be able to participate.
So, talking about your paper, you mention how physician communication styles can become somewhat fixed and unchanging. And I'm just wondering, how does this affect an effective conversation with patients about clinical trial accrual?
Sure. Well, I think it's really natural that people develop a communication pattern that becomes established over time. For example, we become comfortable with a certain way of doing things when we're talking with patients, and certainly clinical practices are always busy. But falling into a really fixed or an unchanging approach can impact your ability to have an effective clinical trial conversation in a couple really important ways. And one is that maybe you're not taking the time because you're comfortable, taking the time that you really should to sort of take a step back, reflect on your communication skills, how you speak with patients about clinical trials, do a little bit of self-appraisal, do a little bit of reflection. And those are all valuable things for all of us to do throughout our lives. And they're simple but difficult to do, but they're really important. And another thing that people might consider doing is asking colleagues for feedback. So another important thing is that we know that clinical trials conversations are not one size fits all. They're challenging conversations, and they benefit and require a certain set of skills. And those conversations need to be tailored to the particular person, the particular situation. And physicians and clinicians don't always have the opportunity to learn these skills in their academic preparation or in their training. Often it's see one, do one, teach one. So, it's really a special skill set that requires time and attention and practice and observance. And it can be one of those things that just sort of, we get caught up in daily practice. We take our communication for granted. And when it comes to clinical trial conversations, it can't be taken for granted. It's really important. And given the magnitude of the issue around insufficient accrual to clinical trials, it becomes really important that people know the most effective strategies to use. And the good news that we try to convey in the paper are that there's evidence-based approaches through communications research that can really help the busy clinical trial clinician.
Yeah, I thought that was what's interesting about your paper was the idea that there is this body of communications research, and I don't think very many clinicians are really even familiar with that such a thing exists,
Exactly. Yeah. It's a real, it's a wonderful area of study. There are wonderful researchers out there. There's really a nice body of literature. And as we began looking at this area, the thing that really struck me is so much of what we think about communication seems to be common sense. With common sense, we might get it right, we might not. We don't have to guess about, what's effective because we've got this body of science, this body of knowledge that can support clinical practice and provide for us interventions that are easy to adopt and really cost nothing. It's that taking that moment and developing an awareness and making a commitment to really think about it. That's so important.
Why don't we talk about some specifics? So in the paper, you discuss some strategies that clinicians might use. And I think the one you started with was the importance of building trust and rapport with patients. And so maybe give me some examples of what are best practices and maybe what you shouldn't say or do.
Yeah, exactly. So building trust and rapport, that just seems like a no-brainer. We talk about it all the time. But, when you really think about it, how do you operationalize that? What does it really mean? And science supports this. The research done by Terry Albrecht and her team talks about establishing a therapeutic alliance and says that patients report that when certain qualities that are used by their physicians, and those qualities are being more reflective, being patient-centered, being supportive and responsive, those are the kinds of things that really influence their decision about participating in clinical trials. A couple other examples, like very concrete kinds of things that people can easily incorporate into practice, are listen to what the patient perceives as being an obstacle to their participation. For example, is it a logistical issue? Is it a childcare issue? Is it an insurance issue? How can you help to resolve some of those issues? For example, if it's a logistical issue, could some of those tests be performed closer to home, for example? Patients say the same thing about side effects. If the physician takes the time and the team takes the time to talk with the patient to help them understand what the potential side effects might be, and more importantly, how the physician and the team will work with the patient to anticipate and to manage those side effects, that's the kind of conversation that patients really find helpful, and it's the kind of conversation that helps to build that therapeutic alliance.
Well, it sounds like language is particularly important, don't you think?
Absolutely.
The one point that was very interesting was you talk about certain metaphors that just creep into our language of describing clinical trials, and I like the one about the flip of the coin. Do you want to just describe that for the listeners?
Because it's something. It's another one of those things that we take for granted. We use metaphors a lot in practice, and it gives us a useful way to relate to somebody and to share a piece of what might otherwise be complex information. So metaphors used correctly can be a helpful tool, but we need to consider the whole context and to appreciate that sometimes metaphors can be problematic. So, for example, using something like the flip of a coin or the lottery or picking a number from a hat to describe randomization, those all seem pretty innocuous. However, there was a study done in 2002. And in that study, they talked about like metaphors and descriptions. And in particular, women and older people felt like using that terminology really trivialized the situation for them. They took offense to it. Yeah, and another thing about metaphors to keep in mind, and it makes perfect sense, is that in order for a metaphor to work the way that you want it to, the patient has to get it. And, getting it really varies depending upon a person's cultural background and their beliefs. So interpretations of metaphors come from one's cultural knowledge. And so the risk of using a metaphor that somebody doesn't understand is that you lose their attention at a point in the conversation that's really important, speaking about randomization, for example, and then it's hard to get that attention back. So it's part of that just perception and nuance. And these are things that we just have to be tuned into and to pay attention to.
I don't think you offered an alternative in the paper, but if we don't describe it as the flip of a coin or a lottery, or do you have some suggestions about what we should say?
Good question. An example that came up, this was from a clinic manager from one of the NCCCP programs, and she described what one of her research nurses did and to explain randomization to patients. And I thought it was great. It wasn't using metaphors. It made it like really concrete. She took colored Post-it notes, one for each drug in the regimen, and could use those Post-it notes, to lay out the various randomization schemas. And it was a way that it was done visually that helped the patient to understand. So, that's different than a different combination of words, but it's just, I think, point being, you sort of have to think creatively about how can we take some of these difficult concepts of randomization and appreciate where people are coming from and tailor our approach to the individual situation.
I would think that doing things in a visual way is particularly important and probably neglected because we're so used to describing things well. It's the doctor sits across from the patient or the research nurse sits across from the patient and just rattles on and on. But that's very interesting. That's clever to do things in a colored paper. I don't think that would have been an obvious choice. Talk a little bit about, you talk about a framework, a formal framework for presenting information. Again, I thought this was kind of a novel point about how to do it in a more organized fashion.
So in the paper, we talk about a 3-part framework for presenting information. And this came from a large NCI study in pediatrics, was the informed consent in the Children's Cancer Group study. And so it used parents of children with acute leukemia. It was interesting because these parents, they studied them for quite a long time, and it resulted in parents making recommendations about how to do a more effective clinical trial presentation and how to have a more effective conversation. And so the parents suggested like using this 3-part framework. And the first stage is to discuss the diagnosis, start there. And in the study, they said that it was just difficult to move forward to anything else until the patient really understood at the level that they needed to the details about their diagnosis and what they could expect. And really at the end of that phase, using open-ended questions to ensure understanding. So not to say, do you understand, but to say, tell me what you understand about your stage 2 breast cancer diagnosis.
Sure.
Then the second stage, having talked about the diagnosis, is then to move into the standard therapy option, to discuss that. And then again, at the end of that, asking for, confirmation, understanding that, or recognizing whether the patient has really, understands everything. And then finally, to move into the presentation of the clinical trial. And they suggest that when you segue into that discussion, to be able to put clinical trials in the larger context of this is how clinical trials improve cancer treatment. This is why people participate in clinical trials. One of the things that the parents highlighted that I thought was interesting was it was really important for them to hear the word choice and to really understand that the trial is voluntary in nature, that they have a choice. And they actually recommended using the word choice at least 3 times in the discussion.
Interesting. Yeah, that's another word that's probably not used enough in these settings. What about the idea of normalizing the discussion about the importance of trials in the first place? And let me just say that this has always been one of my pet peeves, is that too often I think we as clinicians, we see patients who, I'm the first person to mention to them that a trial is a possibility. And while I don't expect the, referring surgeon necessarily to be familiar with all the trials that we have available, it sure makes it a lot harder when this isn't an accepted part of the treatment continuum. So how can we overcome something like that, particularly, when you're talking about a smaller community practice as opposed to, say, an academic setting?
Certainly. And I think you're not alone in that feeling that, gosh, I wish this person knew about clinical trials before they got to me. So the importance of that is, and this was documented in a study, it said that people that weren't prepared in advance to discuss their clinical trials were more likely to be confused by the information that they did receive, and they were less confident about their decisions. And your clinical practice, you probably see that play out, that people, when it's all brand new to them, it's hitting them at a difficult time, it's overwhelming, and it's difficult to make a decision. So that concept of normalizing is just weaving the concept of clinical trials into your entire practice. So there's a lot of ways that this can be operationalized, and they can be done regardless of the size of the practice, large or small. So a lot of organizations or practices have a website. One of the things that can be done, and is often done, is the website will refer to the organization's participation in clinical trials and talk about, why we do clinical trials, why we believe in clinical trials. If your organization does a patient welcome letter or has a patient, orientation package, to be able to include it there. Weave it into the new patient intake process. So, certainly everyone would agree that if the referring physician had already had that conversation, it would make things easier. But if it hasn't happened, there's things that you can do, in the oncology practice to start that conversation. If patient navigators are used, they're a great place to start that educational process. One of the things that can be done at no cost is the NCI has posters that say, ask me about clinical trials, and those can be placed in, waiting areas or exam rooms, at least to help patients think about starting that conversation.
We all practice in teams, and the team approach sounds like it's probably critically important for this endeavor as well as anything else in clinical medicine. But there are different research teams have different components and different roles. And what are your thoughts about the different members of the research team and who should be interacting with the patient? Should it just be the clinician? Is there a role for others to interact, or how does a team work best, I guess, is my question.
Yeah, that's a great question. And every team member, including all of those that you mentioned, have an important role to play. And I think the important thing is that people people's roles are best suited to their strengths, because there's a lot of different ways to sort of organize the work. In the paper, we cite an example from Marge Good, who was with the CCOP program for many years, and she said something I thought was really interesting and really helpful. Her observation was that sometimes nurses were really comfortable talking with patients, and she had other nurses that were less comfortable with that aspect. They were more comfortable looking at eligibility criteria, collecting the paperwork, coordinating behind the scenes. And she said, when it came out at the end of the day, the nurses that were most comfortable talking with patients were the ones that were more successful in recruiting patients to trials. So I thought it was a good illustration of how you've got to have that comfort and that ease in having that clinical trial conversation. I think one of the commonly used models, and a real successful model, is where the physician and the research nurse work together in tandem, as a team, the physician introducing the idea of clinical trials, and then a research nurse or a study coordinator picking up that conversation and describing the study and answering questions. And I think in that model, one of the important considerations is, how is that second person, the research nurse or the study coordinator, how are they brought into the conversation? Are they there in the room when the physician is having the conversation? If they're not, how is the information from that conversation, transferred to the nurse? How does the nurse pick up that conversation and move forward accurately? So I think that there's a number of different ways that roles are organized, and I think the key thing is just that it's coordinated well together, and that you can ensure that information is being provided by the team in a way that's accurate and consistent. And certainly with any team, the larger it is, the more frequently you have a handoff or you need to transfer information, and it's important to have those procedures in place to ensure that those handoffs and those transfers of information are done, done well and done consistently.
I like the idea of having the nurse in the room when you're first talking about the trial. Now, of course, practically that's not going to work some of the time if, there's 4 or 5 patients that need to be seen for trials and the nurse is doing something else, I suppose. But it seems like that would be a good way to give a message to the patient that, hey, this is important, and this is not just an idea that I as the clinician came up with, but I've got these other people here who think this is important, and they're here to support this effort.
I completely agree. My days of actually being a research nurse are, a number of years behind me now, but I really remember the model that we worked in that worked so well for the patients and for the whole research staff. And it was, the nurse was together in the room with the physician when that conversation happened. And so the physician, would introduce me to the patient, and that took the mystery out of it. I wasn't, like some stranger introducing myself after the fact. It was like, okay, my credibility or the introduction was made by the physician. I could watch the conversation that the physician was having with the patient and the family. I could see how the patient was reacting to that. I could, sort of be an observer, keeping an eye on body language and looking for things that needed to be clarified and have some more discussion about. So I think it's really important to think of ways within a practice where that nurse can be in there for the initial conversation.
You talk a little bit about some of the resources that the NCI has available, and can you highlight some of the things that you think are important for clinicians to know?
Certainly. Well, the one thing I would say is important for clinicians to know about is NCI's website that's called Accrual.net, and it's an online resource that we developed a couple of years ago and actually just did a complete revision and revamp and are in the process of relaunching it right now. But it really serves as a one-stop shop for clinicians. And it contains resources for busy clinical trial professionals. So it has things like journal articles, lots of journal articles about communication, as well as other topics, educational tools. We pulled in a lot of the resources that are already available from the NCI, but made them, integrated them in Accrual.net in a way that makes them like really easy to find. So we just sort of collected it all together and made it really useful for people.
And what's the URL of that again, before I forget to ask you that?
It's https accrualnet.cancer.gov.
Got it. Okay. And this complements cancer.gov, the regular NCI site?
Yes. Cancer.gov, NCI has a long history of, creating educational materials. So there are a variety of types of things on cancer.gov for both patients and physicians, a lot of really nice educational tools around clinical trials that are available.
Well, let me ask you the question, the naysayer question, just because I have to ask these things. So people will read your paper, and I hope they do, and I'm sure most physicians who read JOP will look at this and sort of nod in agreement. But there's unfortunately many who are going to just say, well, look, this sounds great, but who has the time? I mean, God knows there's a lot that we have to do, and how do you justify it? So how do you answer those people? I know there's no really good answer to this question, but I mean, what is the return on investment that people should be looking for?
Well, I would say, if people say the cost of conducting communications training is high, I would say the cost of ineffective communication is doubly high. So I think, everybody would love to have the time and the money to be able to participate in a multi-day training, but I think there's other options. That's obviously not feasible for everyone, or until it is, other options to consider. I think technology makes education more and more accessible and easy so that people can do it at their convenience. More and more physicians and other kinds of clinicians are doing online types of training, so maybe that's an option. I'd say go to AccrualNet, start looking at the resources in there. Even if it's not a full-blown formalized multi-day communications education program, start looking at the literature about communication and effective communication, because there's so many things that are so easy to do that cost nothing, don't take a lot of time. It's really that, stop and pause and think about what you're doing and try to incorporate some evidence-based strategies.
And just to clarify, these resources are listed on the AccrualNet site?
Yes.
And can you give us that URL one more time?
HTTPS accrualnet.cancer.gov. I think the problem of clinical trial accrual, Bob, continues to be a really difficult one. And we're talking about how to have an effective clinical trial conversation. And obviously, that's not the only thing that needs to happen to solve our problem of accrual to clinical trials. But I think it's really important. And I think without effective communication, we won't solve the problem. So I think it's important to just take that moment and to stop and to pause and to think about it and to be aware of and acknowledge and begin to incorporate those really simple evidence-based practices into your practice.
Linda, thank you very much for taking the time to talk to me this evening about this very important topic.
Thank you, Bob. It was my pleasure.
And that'll about do it for this podcast. I want to thank my guest, Linda Parreco, for talking about her paper from the September JOP, Power of an Effective Clinical Conversation, Improving Accrual onto Clinical Trials. And as always, please send your comments about these podcasts to jopeditorsdesk@asco.org. This is Dr. Bob Miller for the Journal of Oncology Practice. Thank you very much for listening.